giving me the opportunity to talk about reoperations. I suppose the idea came to Ian because I had about 4 patients from QE referred across for reoperations. I think we've had a lot of data thrown at us over the whole day, and I would like this to be a very practical things that I have learned how to cope with the redo second, third, even a 4th time patient. So I would like to not just concentrate on the mitral valve, but the whole patient. There are certainly some risk factors that have been reported, and this has been talked about all day today. I'd like to touch on when do these valves fail and what do we do at different times. But I'd like to spend some time how to approach these mitral valves when you're reoperating on these patients. We do know that all reports describe the need for reoperations for recurrent mitral valve dysfunction. And this is even though you follow the standardized techniques. These reported incidences can be anything between 90% at 5 years freedom to 85% at 15 years freedom. We also know that mitral valve replacement, by doing a mitral repair, you're not avoiding a redo operations in the future. At 20 years, there's no difference between whether you repair the valve or you replace the valve. There will be the need for reoperations. I suspect over time, we will be forced to do more and more reoperative mitral valve surgery as well. We do also know that mitral valve repair has a high initial instantaneous risk for failure and a subsequent low risk in the order of about 1 to 2% per year. And we also know that reoperations carries a mortality of up to 8 to 10%. We've heard this morning and the afternoon about the risk factors, i.e. the rheumatic disease in the young and in those patients who have active disease. We know those patients who have got severe myxomatous changes, Barlow's, the caudal procedures that have been performed in the past, not to undertake cannuloplasty, and leaving behind residual mitral regurgitations following repair. And there's certainly been a change, there's been evolution in the position with regards to the anterior mitral valve leaflet repairs and posterior mitral leaflet repairs over the decades as we have become more and more accustomed to dealing with these regurgitations. It's true to say that most repairs are surgeon or procedure related for degenerative disease, and I'm using the word most over here, but it is valve related when it comes to rheumatic. And Duran has also classified that if you have had to do a reoperation on the mitral valve, it is because you've done the wrong operation in the wrong patient. There's been a technical error. The procedures that you have used has resulted in unstable techniques, and there's no doubt there's progression of disease. We talk about freedom from reoperation as a goalpost on describing failures, but I think this has been alluded before. I think we need to talk about not only freedom from reoperation, but freedom from significant mitral regurgitation. And you can see that very good data when it comes to survival, when it comes to freedom from reoperations. But when it comes to reporting using freedom from severe mitral regurgitation, there is a vast difference in this same group of patients. And this is also reported, and from what I understand is one of the big series from Tyrone David. It shows that when it comes to reporting freedom from reoperation, it is different from when it comes to freedom from severe mitral regurgitation. And that, hopefully, one day, we will try to get it as good as a curve there. It's true to say that we should never have a patient leaving an operating theater without any mitral regurgitation or mild stenosis, but we have, over the period of time, accepted grade 1. And I think we have to understand to take the whole patient in totality rather than just get sort of focus on the mitral valve. Thankfully, the incidence of regurgitation is reducing with increasing institutional individual surgeons, echo monitoring, and knowing that we got to preserve the leaflet motion, the coaptation zone, the remodeling of the annulus, eliminating some of the unsuccessful techniques such as chordal shortening procedures. There has been some decrease in the prevalence of rheumatic disease, and through training, mentorship, and outcome reporting. But I would like to sort of note that we must exercise some of the caution on the techniques that deviates from established principles, and modifications, if you do use them, are neither reproducible or have proven to be durable. So, reoperations for the failed mitral valve repair, and I must say, not to encounter these failures, you have not done enough mitral repairs. So all of us have collection of patients who have been failed by us surgeons in instituting a perfect repair. They can be classified into immediate failures, those failures on the table and before they go home, early failures up to 2 years, and late failures. I think Frank and others have talked about the medium or immediate failures, and I won't spend too much time. Apart from, I think most or quite a few of the patients who have got regurgitations either on the op table or following surgery is as a result of this interscallop leak or indentation, which are very deep and have not been dealt with properly. And because this is something, this talk is about tips and tricks. By just putting a stitch on an indentation and hoping to get rid of this leak will fail. What you have to do is you have to divide those primary chords in the depth of that indentation, and then you have to stitch it. If you don't divide those primary chords, then you will have further restriction and you'll end up with the continuation of the leak. So divide those primary chords which are in the depth of the indentation. The suture dehiscence, invariably, this is as a result of too much tension on the suture line. No point putting some more stitches in the suture line and hoping that you'll get away with it. You have to undo the whole annuloplasty, and you've got to do further annular plication, and then perhaps put some stitches, or you can then use some autologous pericardium. The others are kind of easy to deal with, and I think our echocardiographers and our anesthetists can help us to identify exactly where the leaks are, and there are simple, straightforward procedures that can be applied to sort these leaks. Rheumatic disease. Patients leaving theatre or leaving the wards with anything like 8 millimeters of gradients and pressure half-time of less than 2, I would say that is a failure. These patients will come back and hound you in a year's time or so, and then it becomes very difficult to go back into the chest. I suspect that these patients, you should call it a day and replace these valves with the preservation of the code as Frank described. I don't spend too much time on SAM that's been talked about today. These early failures, what do you do? The ring dehiscence, fix the ring. If the leaflet suture dehiscence, as I said again, that this suddenly doesn't happen about a year or two after surgery. I suspect there has been suture dehiscence for a while. In these patients, you take the ring off, you do further work on the annulus, and you downsize the ring. If there is a big gap in the API position, you downsize or get the right correct ring and put it in. Commissural leaks, edge to edge, and the commissure or a Gore-Tex code. If the codes are elongated or ruptured, triangle resection and some Gore-Tex codes. Now this business about thickening leaflets, decrease leaflet motions, Carpentier describes as a leaflet hypertrophy or leaflet distension. These are due to regurgitant jets that are coursing over the leaflets. These are myxomatous disease or fibroelastic disease, but when they come back again 4 or 5 years down the line, these leaflets are extremely thickened, and that's because of the jet, which is coursing on the surface of the leaflet. I think for these conditions, you have to, again, take down the ring. You have to then extend your leaflet to allow better mobility of the leaflet and size your ring appropriately and correct the regurgitation. For the rheumatic, it's common sense. This is further retraction, and I just call it a day and replace this with valve preservations. Hemolysis has been touched upon, but I've got one slide here which people don't talk much about hemolysis, but this is a real entity. And if you have got mitral regurgitation following surgery, if you look hard enough, there is a degree of hemolysis in many of these patients, and can present at any time following surgery, is characterized by persistent anemia, raised LDH, haptoglobulins, and the peripheral smear will quite often give us an answer as to and confirm the diagnosis of hemolysis. But there will be low-grade hemolysis, and you will not have changes in the peripheral film. It has been well characterized as fragmentation, when the jet is divided by a solid structure, usually an annuloplasty. So you've got an annuloplasty sitting there, and the jet is coursing, and you get then fragmentation. Collision, when the jet comes and there's sudden deceleration, and therefore, as Carpentier has taught us, do not use Teflon pelagics anywhere near and around your leaflet tissues. You get rapid deceleration, rapid acceleration, and this is through the small defects. These are high velocity defects. And again, these high velocity defects are striking the ring. These are large volume regurgitations. This is a central jet which is hitting the roof of the left atrium, striking and producing hemolysis. And this is slow deceleration, and that is the jet lesion hugging the wall of the left atrium. The commonest problems are in the first two. There's fragmentation, collisions, and perhaps a little bit more on this rapid acceleration. The treatment for this, you identify the cause. Always there is mitral regurgitation, and you have got to either proceed to repairing them, or as if it is beyond your ability, then just replace these valves. What about late failures? Again, you will have some ring dehiscence, simple ring refixation or replacement. Leaflet prolapse with new chordal rupture and elongation. For these ones, I have actually taken the ring off, and then whatever I had to do, again, going back to your basic primary principle in addressing a type 2 problem. Leaflet fibrosis, replace the valve. Leaflet tethering, you can extend it, and or you can replace the valve. Again, for the late stenosis and the rheumatic ones, you replace them. However, if you have a patient in whom the failure is rheumatic and has occurred beyond 10 years, you may wish to do further surgery of the rheumatic valve and may give you a good result. But certainly those young patients with active rheumatics, you should really just remove them. And if they're heavily calcified, you remove them with preservation of the chordae. These patients do need a bit of workup. Apart from the routine tests, a CT scan is extremely important. And also, with these patients, we've got to have a very clear, precise mechanism of the transesophageal echo. And I do believe that this patient should have a toe before they go to anesthetic room. Of course, they will have a toe in the anesthetic room, but you have to see exactly what the causal mechanism is and decide whether this is going to be a complex re-repair or there's going to be a simple re-repair. But the analysis has to be done before the patient goes to theatre. Reoperation, generally there is reluctance to reoperate on these patients, and the operation is quite often delayed. The patients are sicker. Pulmonary hypertension, severe TR, severe RV dilatations. In those elderly folks with these high-risk patients, do consider bringing them in, oxygen therapy, milrinone, prostacyclin, furosemide, dobutamine, There was some drugs that were reported, but has not been substantiated to improve the outcome of patients. Next thing is really, once you have got this regurgitant valve, what are you going to do with these patients? I think it's important that we understand how we're going to approach this. Are we going to go through median stenotomy or other ways? Which patients should have a median stenotomy? Obviously, those patients who need grafting on the left side, need an aortic valve replacement, you will go through the midline stenotomy. The advantage is we're familiar with this approach, and we can do over maze procedures if necessary through this procedure. The limitations are, if you've got an aortic prosthesis already in a patient, it becomes extremely difficult to expose the mitral valve for these patients. Do a low stenotomy incision, because quite a few of these patients will require a tracheotomy to wean them off ventilator. What about cardiopulmonary bypass? You can either go on to central cannulation in the usual way, but I would urge us to think a bit more in trying to use more peripheral cannulation. And the hint over here really is to drop your left pleura completely, restrict your mobilizations, and don't pull on the peptic muscle because they will tear off from the LV wall. Now, what I've been trying to do more and more now is to actually undertake peripheral cannulation, and there are advantages of this is really you reduce injuries to the RV, RA, and if they do occur, you can have a good control rapidly on it. It does reduce your operative time and allows you to dissect the heart and the pericardial lesions with the heart collapse. And again, the advantage is there's no cannulas in the field. The disadvantage is really there's extra incision there, but this is the most dreadful complications. We have got to now begin to really start looking at legs, looking at arteries, how we're going to standardize our approach to the femoral arteries in cannulating these. It does increase overall bypass time of excessive bleeding, and there are reports of increased CVAs because of the retrograde perfusion of the femoral artery. I just want to spend 30 seconds or so on peripheral cannulation. What I do is to expose the right common femoral artery through a transverse incision, no dissections. You palpate the artery for a soft spot on the anterior wall, apply your Godex sutures in a U manner. There's no occlusion, so you insert your cannula through a totally Salniker technique, through toe guidance. We insert a right jugular cannula and position this under toe guidance in the superior vena cava in the RA. We will then connect this one to the cardiopulmonary bypass and apply suction and then do a stenotomy. If you get a good drainage, we'll stop the ventilation and do the stenotomy. If the drainage is inadequate, you continue ventilating. What I then do is to position the cannula through the femoral vein to establish complete collapse of the RV and RA before proceeding to stenotomy. So this is now becoming more and more of a standard cannulation for stenotomy for redo mitral valve surgery. What do you do? We will see quite a few patients now coming in who have had revascularization in the past and have who need mitral valve surgery, who have patent memories. What we do is we just ignore the memory, let it flow and perfuse the arrested heart, moderate hypothermia. We can reduce the flow rates. That helps in giving us a bit better blood flow, blood-free view of the mitral valve. We replete it every 20 minutes or so. I think trying to dissect these memories in a pedicle form, clamping it, using profound hypothermia, or selectively perfusing down these memories by the cardiologist putting a catheter up the memory and then perfusing, I think is all a bit too complex. I think you can just ignore all that and just get on and do the mitral valve surgery with the heart being perfused with the memory. And there's publications to substantiate that policy. If you have aortic prosthesis in situ and you have to do the mitral valve, or if you choose to do mitral valve electively, we have chosen right thoracotomies, and don't be fussed about small holes or bigger holes. You're going there to fix the mitral valve, and we'll just do standard fourth intercostal space incisions. Whether you use portholes or you make a large incision will all depend exactly how much through the training you've been through in port access surgery and so forth. But that's immaterial, really. You've got a valve here you've got to fix, and how big a hole you leave there or smaller hole you leave there is immaterial. Which patients? Those patients are patent grafts who have got who do not need any other surgical procedures, who you cannot clamp the aorta because it's either severely calcified or diseased. The advantage is that there's minimal dissection. There is a direct visualization of the mitral valve. It's certainly contraindicated in those patients who've got moderate aortic regurgitation. Remember, you will not be able to clamp this aorta, so the heart is being perfused all the time. The heart will be fibrillating and beating at occasional. So, yep. You have got to make sure you've got no aortic regurgitation. Okay. For the sake of time, I think the cannulation is just like you would do for minimal invasive mitral valve surgeries, which has been well described by Castleman and Hugo Wernemann as to the neck cannulations and groin cannulations, 4 portholes if you're going to decide on port access, redo mitral valve surgery, and you can enlarge your working port as much as you can. Just a little tip with regards to exposure. If your exposure is poor, snare your cavities, and this incision I found quite useful sometimes to expose your mitral valve. So if you're struggling, don't pull too hard, because what happens is you tear in this roof of the left atrium. So you've got to dissect this area, lift the SVC up, and separate that plane between the right pulmonary artery and the roof of the left atrium. You need to be familiar with long shaft instruments and have them in your theaters. What to avoid, redo surgery is closure of the left atrium. The roof of the left atrium can get caught, the PAs can be caught. You can cause SVC obstructions, and you can sometimes strap your Swan catheters. All this has happened. And as I said, dissect that the roof of the left atrium when we're approaching mitral valve, be it by stenotomy or by right thoracotomy. Just the last slide, this is on de-airing, never to be forgotten, really. I think by this time the surgeon is too tired and does forget about de-airing ritual, well described, passive and active de-airing that you can and must undertake in patients with any form of mitral valve surgery, let alone redo. This cannot really be undertaken very easily with right thoracotomy, but in circulation of CO2, you can certainly undertake all these procedures, and this area here, you can tip the aortic valve, let the blood flood the left ventricle, and by suctioning the catheter inserted through the mitral valve, you can remove a lot of air, and a needle in the roof of the left of the aorta will help you with that as well. So I hope that this has been a very brief run through some practical things that one needs to take into account when you're tackling redo mitral valve surgery. Thank you.